Mhm. Okay, perfect. All right, so I'm going to go ahead and share my screen. And again, like I said, I'm going over the PowerPoint and some of the things that I noticed students frequently miss. And we have a few of you that I haven't said hello to. So hello, if I haven't said hello to you, please put any questions in the chat. I'm happy to entertain those. If you have any questions after this hour, I know Dr. Selassie is going to be on at 11 to 12. So he'll be covering some EKG tips and highlights as well. But I love EKGs. And so if you have any questions, feel free to reach out to me. I love to kind of decode these. Okay, so you guys know about the electrical activity. And I know we're starting really basic, but we're going to get right into it. So remember the SA node, the sinoatrial node, that's where all sinus impulses come from. So if you have a sinus rhythm, it has been started at the SA node. The SA node fires, sends the impulse to the AV node, and then the AV node captures it, holds on to it ever so slightly, and then it sends it down the bundle of His, and then it splits to the bundle branches and all the way to the Purkinje fibers. There are 3 areas on here that initiate impulses or are able to initiate impulses. The first one is the SA node, and how fast does that fire?
60 to 100.
You got it. The AV node can function and it can fire independently, and if it does, how fast does that fire?
40 to 60.
Thanks, rock on. Okay, and then from there, the bundle of His, that's just a highway, okay? So conduction isn't being initiated there. That's the highway. And the bundle branches, those are the highways, okay? And so nothing's really being initiated there. It's being carried there. But if the SA node and the AV node fail, there's always the Purkinje fibers deep in the ventricles. And if those fire, they're going to fire pretty ineffectively at 20 to 40 beats per minute, okay? That is the final last resort pacemaker. Okay, so you guys know the 3 areas that can fire. Perfect. Okay, so we've seen all of this. You can see how if you have any blockages in your coronary arteries, it's going to affect the conduction, because remember, if the heart is not getting oxygen, dead meat don't beat. Okay, that's how I remember. If there's issues in the myocardial tissue, if that's not getting oxygen, there's no electricity or conduction going through there. You guys remember how to measure time on an EKG strip? You guys all need to know this. We can't move it any further until you do know this. The little box is 0.04. The big box has 5 of the little boxes, so it's 0.20. And every strip that we give you, you can go ahead and just assume that it's 6 seconds. You guys know what each of these is. Okay, so the P wave is the atrial kick. That's when the sinoatrial node fires. The PR interval, remember that's a little bit tricky because it's from the beginning of the P to the beginning of the QRS. Even though it's called the PR interval, it's really from the beginning of the P to like where the Q is. So PR interval, it needs to be 0.12 to 0.20 seconds. If it's any longer than that, you're going to have a 1st degree AV block, or any other kind of block for that matter. Your QRS, remember, this waveform is where the ventricles depolarize. That is systole. It's when the heart beats. Okay. This is super narrow because remember, that impulse is following that bundle of His and bundle branch highway, and it goes really fast on those highways. That's why it's narrow. And then we've got our ST segment. What if that ST segment is elevated? What does that mean?
And the MI.
Yes, right? ST elevation MI, okay? Injury has already occurred. What if the ST segment is below the baseline? ST depression.
It's depression. It's like ischemia.
Ischemia.
Right? Hypoglycemia.
Oh, you need oxygen.
Oxygen. Yep, absolutely. So if the ST segment is low, You need oxygen. That's ischemia, okay? And then, of course, your T wave is repolarization or relaxation of the ventricles. If you're wondering, where do the atria relax? That's hidden in the QRS, okay? This impulse is so much stronger than repolarization, so you're not going to see it. Can you guys see my mouse where I'm kind of pointing? Okay, perfect. All right, I'm moving on. You guys stop me if you need me to slow down. U wave, you know, is hypokalemia. It's very rare. This is an old strip. I probably have only seen this a few times, but if you see a U wave, think I need to check those electrolytes, especially potassium. Tall tinted T waves, what does that mean?
Potassium's high.
Yes, high T waves, high potassium, okay? This can also appear with ischemia or an infarct as well. Nice. I don't know who said that. Who said that?
Grace, good morning.
Grace, good morning, fist bump. Okay. You guys know about placing leads and why we place the leads in different places. Remember, when we look at our EKGs, the lead that we look at is just an angle. It's just the way that we're looking at it. So we want to read everything typically in lead 2. It's the easiest lead, and that's going to be from the right arm to the left limb. So it's reading it across the body like that, okay? In lead 2, you'll have an upward facing P, an upward facing QRS, and an upward facing T. Stacy, that's a cute cat. If we were to read that the other way, from the left limb to the left arm, things would be upside down, okay? So just know that when you're looking at different leads, they might be upwards or downwards, but we're going to look at lead 2 typically, and you'll have everything facing upward. 12 lead ECG, again, we're going to look at lead 2. This is a terrible EKG. Our patient is having some trouble here. So, but just for instance, in lead 2, like I said, everything's going upward. But if you look at some of the other leads, they're being read from a different direction. And so that's why the QRS is downward. Wish I knew that in school. We talked about ST elevation, which would be myocardial injury has already occurred. That's an infarct. There it is again and again. And then we talked about ST depression. What I like to do, because I know it's a little bit hard, I like to imagine the baseline. It's also called the isoelectric line. And sometimes I'll even put a piece of paper right on it and see where it is, okay? So I can see right here that the ST segment creeps up to that baseline, okay? Oops, sorry. Don't worry about this one. There's all kinds of different ST depressions. ST depression is ST depression. That means ischemia and the patient needs oxygen. Am I moving too fast or are you guys good? Okay. All right, so we've got all kinds of ST segments here. Please know these, but again, you've got your normal, your ST elevation, your ST depression, and then a T wave inversion, which would be a non-STEMI. This is a very important slide. I'd print this one out if you can, because this is what you're going to do when you're starting out reading EKGs. So I have mine even printed out right here, because when you look at a strip, sometimes you're like, where do I start? I like to try and find the most normal part of the strip first. So we need to see the rhythm. Is it regular or irregular? Remember, we're seeing if the top of the QRSs march out. And again, sometimes I use a piece of paper to do that. I line it up and I mark where the R is on each one, and then I move it down to see if they're equal. So feel free to do that on your exam as well. The normal rate, you know, is 60 to 100. We want a P wave before every QRS, because if we have a P wave, that means it's starting from the SA node. We have a sinus rhythm. We want the QRS to be present and narrow, less than 0.12 seconds. Remember, if the QRS is narrow, it's following the bundle of His to the bundle branches and going through the ventricles on that fast highway like we want it. If it's wide, it's not following that highway. It's going cell to cell to cell to cell, which is slower. And then the PR interval from the beginning of the P to the beginning of the QRS needs to be less than one big box, basically. All right. We know we have a regular heart rhythm. I'm going to kind of skip through these, but you know that these march out. They're equidistant. That's an irregular heart rhythm. Estimating, remember, you can assume that all of your strips are 6 seconds. You're going to count your QRSs and multiply by 10. We calculate the heart rate here. Somebody help me.
30.
Thanks. All right, perfect. 30. Easy peasy. We've got 80 here because there's 8 QRSs. The heart rate here, we've got 2 different rhythms. So we got a fast rhythm and a slow rhythm, but ultimately our heart rate is 140. There's 14 QRSs in here. And then the same thing, we actually have our QRSs here. We have PVCs here, but these are still QRSs, so we're going to count those as well. Okay. When we look at this beat, just kind of going forward, because you've had this lecture before, we've got our P, we've got our QRS, and we've got our T. Okay. This is following the bundle of His, bundle branch pathway, that fast highway. It's nice and narrow. This one is going cell to cell, and it's wide, and it's taking a long time. So that's your PVC right there. You've got a normal sinus rhythm. There is only one rhythm, guys, that's normal sinus rhythm, and that's normal sinus rhythm. If there's anything not right about it, it's no longer normal sinus rhythm. So sinus bradycardia is not normal sinus bradycardia because it's not normal. It's less than 60. So it has to be perfect within those 5-step parameters to be a normal sinus rhythm. All right, so if you're doing the interpretation, you want to look at those steps. It's regular. The rate is 60 to 100. There is a P before every QRS on the whole strip. The QRS is present and it's nice and narrow, less than 1 big box. And the PR interval is less than 1 big box as well. When I look at my PR interval, I find one that starts on a big box right here. Okay. And then you can see it's less than 1 big box right here. These are all coming from the SA node. They are the same waveform no matter where you take it from on a sinus rhythm like this. So find one that's easy to measure. Start on a big box and just make sure it ends before the next big box. Does that make sense? Okay, so what do we need to do for this patient? We document. Okay, this is a normal sinus rhythm. Sinus bradycardia, if we went through the same steps again, everything looks good except for the rate. Okay, so the rate is 50. And for this patient, we need to check if they're symptomatic or asymptomatic. A lot of people walk around with this rhythm. Your athletes will, young folks do. If they're symptomatic, we need to give them atropine first, then epinephrine or pacing.
I have a question. Sorry to interrupt.
Yeah, absolutely.
So I know she's very strict on naming or having the correct or exact name. So when I look at this, I could say, okay, you know, he has bradycardia, but I don't know if maybe you could explain like the sinus part. Like we have to put this. She says that we have to put sinus bradycardia. Who bradycardia is wrong. But like for me to look at this, is there a way maybe you could explain like why is the sinus?
Michael, you got it. So absolutely. It's sinus because it has a P wave before every QRS. So it's still starting from the sinoatrial node, thus making it a sinus rhythm.
Perfect. Thank you. That just cleared that out.
Okay, perfect. All right, good question. Thank you so much. All right, so again, for this patient, we check for symptomatic or asymptomatic. We give atropine first and then epinephrine or pacing if our patient is symptomatic. Supraventricular tachycardia, this is a hard strip to see. We do realize that it's hard to come through, but basically supraventricular oh, I'm sorry, did I say supraventricular? We're on sinus. See, I just made my first mistake, and mistakes are okay here, not on the test, right? So it's sinus tachycardia. It's still a sinus rhythm, Michael. It's got that P wave before every QRS coming from the SA node, but the rate is greater than 100. Our rate is 140 here. What do we do for this patient? We need to find the cause of this. So that could be anything: stress, exercise, fear, temperature, maybe decreased blood pressure, dehydration, caffeine, alcohol, nicotine, albuterol, could be the patient's baseline. Supraventricular tachycardia. This is a rhythm that is a narrow, complex, regular rhythm greater than 150 beats per minute.
Can you
The
say
P
that
wave,
one more time?
yes, it's a regular. So look at the QRSs; they're equidistant. It's a regular, narrow QRS complex rate that's greater than 150 beats per minute. This happens to be 180 beats per minute. The P wave is not identifiable on this because it is so fast. So we can see the QRS here. And then what do we have here, guys? With this,
Depression, ST depression.
yes, we would expect that. Someone whose heart is going this fast and isn't filling very well, they're going to have some ischemia. Good catch. But then it rises up to the T wave, and then it's so fast that by the time we see any P waves, it's already QRS time. So any P waves are buried or hidden in the QRS. What you need to remember for this one is it's regular, narrow QRS, greater than 150. Okay. Treatment. If they're stable, if they're tolerating this, and most patients will initially, we do vagal maneuvers. We can use rapid administration of adenosine. I think I've got a video in here for you guys. It's a good one. You can watch that on your own. And then if it's unstable, you can cardiovert this patient. Okay. We talked about vagal maneuvers, so you guys have that. You can see someone with SVT. Someone did a vagal maneuver right here, and then it slowed down. I can't tell exactly what rhythm this is. I can't tell if that's a P wave possibly, but they look a little bit different. It's some kind of a slower rhythm. We'd have to see more of the strip, but you can see you still have that ST depression. So just because they fixed it right there, the patient's not going to be better immediately. They're still going to have some of that ischemia as well. All right, sinus arrhythmia. This is a very, very common thing, and it's related to breathing. So when you inhale, the heart rate goes up. When you exhale, the heart rate goes down. So you think about it, it's just changes in vagal tone during respiration. So you think about if you like breathe out really slow, it slows your heart rate, right? So that's what's happening here. But basically, it's a sinus rhythm because we still have a P for every QRS. Everything is normal here. Everything looks beautiful here, except these just don't march out exactly. Okay. A few of us probably have this right now. No biggie whatsoever. All right, so I want to stop here and talk. We've talked about rhythms so far. So there are EKG or ECG rhythms, but then there's also features. Did Dr. Haylett talk about features with you guys? A little bit. Okay, so I want to stay on this for just a second. Features are specific characteristics within a strip that are not naming the whole strip. So we never have a strip that's called PACs. We have a rhythm with PACs. Okay, PACs, premature atrial complexes, are a feature. Premature junctional complexes, feature. Premature ventricular complexes, feature. Those are never rhythms on their own. It's a very commonly missed item right there. We have to see what the underlying strip is. So when I look at this strip, I'm like, oh gosh, where do I start? Guess what? Find the most normal part. I'm looking at this beat right here and I'm like, oh, that looks pretty good. We've got a P wave, we got a nice narrow QRS, and we've got a T, but then we've got another P wave. And you can see it's different from this P wave. It's following a different pathway. This is not coming from the SA node. So a premature atrial contraction is an impulse generated from a site in the atria other than the SA node, and it comes early. Every P wave, normal P wave that comes from the SA node, the sinoatrial node, will have the same waveform because it's following the same path. But if we have an impulse originating in an area not the SA node, it's going to look a little bit different. It's premature and early. So if we're looking at this whole strip, we've got a normal beat here, and then we've got a normal one here, and then we've got a P wave that comes early, and the QRS follows. We've got a normal beat here. We've got an early P that looks different with a QRS that follows. This is sinus rhythm with premature atrial complexes. Is this a normal sinus rhythm? Okay, is it a normal sinus rhythm with PACs?
No.
Got it. There's only one rhythm that's normal, right? And it has to be perfect. So this is sinus rhythm with PACs. Does everyone have this one? Okay. Speak up if you don't. All right. Premature junctional contractions, PJCs. Those are going to be impulses generated early, and they're generated near the AV node. Okay, so if we have a heart and we've got our SA node and our AV node, a normal P is going to come from the SA node and go to the AV node. A PAC is going to occur in the atria at a place other than the SA node. PAC, it's in the atria, it's originating from the atria. PJCs are going to originate around the junction, the AV junction. So it's going to be a cell around there that's a little bit irritable. Okay, so PJCs, you know it's a PJC if the P wave is either absent, I'm looking at it right here, buried in the QRS, after the QRS, which is rare, or inverted. Remember again that this is a feature, so we have to look at the underlying rhythm. I see one wacky beat here, but the rest of the rhythm looks really great. I've got a P wave, I've got a nice narrow QRS. Of course, we can measure this, but just looking at it, it's nice and narrow. It's probably like 0.8, 0.10. And then I'm not really seeing a great T, but I'm not too worried about it. P wave, QRS, T somewhere in there, P wave, QRS. So we've got a sinus rhythm, but then we have this wacky premature beat right here that there's no P wave. So we know that that's a PJC, a junctional contraction, premature junctional contraction. So remember, junctional, the P wave is either inverted, so it'd be upside down, absent or buried in the QRS, or after the QRS. Is everyone on board?
So when you say the feature, just to kind of make more sense of it, so it's more like you have kind of, I don't want to say a normal sinus rhythm, but you kind of have something normal going, and you have like a little bad guy in there that's just kind of like just bad.
Yeah, but we could have a bad rhythm with a bad guy that's different too. So that's a good point as well. You have an underlying rhythm, and then you're going to have these features that occur that are not every beat. So for instance, we could have maybe an atrial fibrillation with a PVC. So we might not have a great underlying rhythm, but we could still have these features as well.
Got it. Thank you.
You're welcome. Great questions, guys. Junctional escape rhythm is when every beat is coming from the junction. This P wave is inverted right here, okay? So, but it's inverted on every single one, okay? So we no longer have a sinus rhythm here. We have a junctional rhythm here. I hope that makes sense to you. We only have a sinus rhythm if we've got a P wave that is acting appropriately, right? This P wave is not coming from the SA node at all. It's inverted. Or if it was absent, it's coming from the junction, the AV junction, those cells around the AV node. Something's irritated there and firing.
Okay, I have a question.
Absolutely.
Okay, so you said, okay, so if it's inverted, that's bad, but the whole thing can be inverted and it's fine? Like, that's where I'm kind of confused.
Great question. So if you have a sinus rhythm with like a PJC somewhere, it's pretty benign, okay? It's not going to bother your patient too much. It's just every now and then. If it's every beat, you're losing your SA, your atrial kick.
Okay, yeah, so now it's down to the AV, right?
Almost down to the AV.
Almost.
Yes, if it was the AV, Melissa, your rate would be between 40 and 60.
Okay, so that's where I'm kind of confused because I have the notes from the original lecture and I wrote 40 to 60 beats per minute on this slide. So
it can be, or it can be accelerated junctional as well. We didn't really specify in between, but because it's so close to the AV node, it's going to be around that rate.
Okay.
If you have an impulse coming from the AV node, it's not typically going to have this narrow QRS.
Okay, so back to what I was confused about originally was, okay, so an inverted P wave with everything else flipped on the regular side is bad. But then if everything's flipped, like if everything's inverted, you're just reading it diagonal in a different direction is what I'm saying?
Correct.
Like that, like the inverted things really confuse me.
Absolutely. And I think it's a little advanced. You guys need to know it, but that's tough. In lead 2, and this is lead 2, it doesn't say it, everything should be upright.
Okay.
It's the easiest lead to read. And so everything should be upright. So we can see that this is an issue. If we were reading a V lead or something that was reading from bottom to top, then everything would probably be upside down for the most part. Okay,
right.
Generally speaking. Okay, can I move on from this slide, or do you guys need another?
Yes.
No. I have a question.
Right.
I'm just trying to differentiate between this slide, the junctional escape, with the one before, the premature. Can you correct me if they're both, the PQRS are both narrow, but with the premature, that's when you have like that one bad guy versus the junctional, which is they're all kind of inverted, because you said the PJC could be inverted sometimes. So this one that you have up now, it's just like kind of everything looks good except for one.
Correct.
But then the next one, it's kind of the same features. It can be inverted, but it's just more. They're more consistent, right?
Yes.
Okay.
Kind of.
It's a
Yes,
difference.
absolutely. So the difference is we have an underlying sinus rhythm here with just one. Sometimes there's two. I'm not saying it's always one, but we have a feature here.
Okay.
Okay. This nice strip is wearing an earring.
Okay.
It's called a PJC.
Okay. I remember it like that.
It's every single beat, so it's its own rhythm. It's no longer a sinus rhythm because the P wave is not coming from the SA node. It's now coming from the junction, the AV junction. So this is its own rhythm. It's a junctional escape rhythm.
Okay, thank you.
You're welcome.
I just had one more question. So, I think she said it's going to be multiple choice, but just in case that there's like fill in the blanks, if we were to be asked the PJC strip before, you wouldn't say normal sinus rhythm because there's an issue. You would just say sinus rhythm with PJC feature?
You can just say sinus rhythm with PJCs.
Okay.
Or even PJC is fine.
Okay. Thank you.
You're welcome. Alexis, right? I can't see all of you.
Yeah, it's me.
Okay, good. I can hear your voice. All right, perfect. Same thing with PACs, same thing with PVCs. So even when you get your test, maybe just write yourself a note on it. features, PAC, PJC, PVC. Those are your features, okay? There is one other feature, and that's a first degree AV block. It can't be its own rhythm, but we'll get there. All right, so we talked about that. Atrial flutter, that is when the SA node is firing too rapidly. Okay, remember SA node typically fires 60 to 100 beats per minute. Well, in a flutter, sorry, the SA node is firing about 300 beats per minute. The AV node is smart though and doesn't let all of those through. We don't have 300 QRSs. It's only letting some of them through. It's going to have a sawtooth look to it. So you can see we've got, this is actually a P wave, and then if you look in here, there's actually a P wave in here as well. It's just the QRS is stronger, so it's kind of hidden behind it. But it has that sawtooth feature. This is all SA, okay? I cannot see a T wave because it's buried in all of these P waves. So remember that these are typically regular and they have a sawtooth feature. That's not the right word for it. I don't want you to think it's a feature. They have a sawtooth appearance. You guys have the causes for this and the treatment, correct? You got that in your lecture and notes?
Yes.
Okay, I have some yeses and some nos, and so I'll
Did we?
pause.
All right.
I'll pause
It's on
right here.
this, I don't know. It's like they printed off this thing and it has everything on it. It's perfect.
Oh,
Never seen
okay.
anything
You're
before.
the other thing in modules that said yes. Okay.
Yeah,
Gotcha.
that one's good.
Yes, I hope this helps you guys. That it has all of the rhythms and what it's caused by and what the treatments are. So you guys can refer to that. Atrial fibrillation is when there is one cell in the atria that is irritated. And it's upset because it doesn't have oxygen or there's an electrolyte imbalance. And it's just firing away, okay? So atrial fibrillation, when we're looking at this one, it's going to be irregular. If we look at the tops of the QRSs, it's irregular. When we look here, we've got all of these firings right here, okay? So we've got, you know, I think I said one cell. I'm sorry, guys. It's multiple cells. I'm looking at this and I'm like, that's not what this is. It's multiple cells in the atria that are very upset, and that's what's causing all of this stimulation up in the atria. It's causing all of this quivering. It's chaotic, uncoordinated. I cannot find a P wave in here. The QRS is typically normal. There's no issue from the AV standpoint or in the ventricles. Okay, it's narrow. It's following that bundle of His and bundle branch pathway. If it's under 100, this is atrial fibrillation with a controlled ventricular response. If it's over 100, it's atrial fibrillation with a rapid ventricular response. Have you guys heard of AFib with RVR? Okay. If a patient has atrial fibrillation, new onset atrial fibrillation, what do we need to give them first? Does anyone know?
Is it a medication or is it?
It's a medication.
Okay.
Lots of blood is pooling.
Is it adenosine?
No, it's going to be heparin.
Oh, heparin.
Yes, for this one. Okay. I'm glad you said that because that gives me something else to clarify. So atrial fibrillation, remember the atria are just kind of quivering up there. Blood is pooling. There's clots forming. We need to anticoagulate this patient. Okay. You mentioned the medication adenosine, and that's used for one rhythm, and that's supraventricular tachycardia. That is that regular narrow complex QRS that's greater than 150. In real practice, all the time, we have patients that are either in atrial fib or SVT, and they're really hard to tell apart. In fact, you know, we'll be there with the cardiologist and I think it's this. No, I think it's this. Strips are a little hard to look at sometimes.
Okay, I was just looking at the next one and it says like we are gonna cardiovert them, so that's why I thought the adenosine because the cardioversion.
Okay, thank you. I'm glad you said that. So just to clarify, SVT is the one with the adenosine as well. Okay, we can cardiovert someone in atrial fib, and that is another treatment. But remember, our number one concern is blood clots. So we need to give heparin first, and then the patient will probably go home on Coumadin. The difference between atrial fib and SVT is atrial fib is irregular. Okay, these are not coming from the P wave at all. These are coming from multiple irritated atrial ectopic foci. Ooh, that's a mouthful, right? So when I talk about ectopic, kind of like when we think about ectopic pregnancy, coming from another area than what was intended. So if we've got an ectopic focus in the atria, that means it's a cell other than the SA node. All right. Nice, Melissa. You mentioned this one. Yes, we can cardiovert this person, but we would want to make sure that they're anticoagulated first. All right, we went ahead and put some of this on the slide because this is very important. I know these slides required you guys to take some more notes, but you're ready for that for certain. You're about to graduate. So PVCs, here are your causes. This is another feature. It is not a rhythm on its own. This is caused from an electrical discharge from a ventricular focus that is not the AV node. So when you think about your heart, right, you've got your SA node, your AV node, your bundle of His, the branches that go to the Purkinje fibers. Okay, with a PVC, there is an irritated ventricular ectopic cell. An ectopic focus that's firing. It's mad because it doesn't have enough potassium, mag, maybe the calcium is off, doesn't have enough oxygen, maybe it's super stimulated from caffeine or smoking, stress, okay? And it's gonna fire and it's gonna go cell to cell to cell to cell. It's not gonna be on the bundle of His bundle branches to the Purkinje fibers. Remember, that's that fast highway that makes a narrow QRS. When we have a PVC, that impulse is coming from a ventricular cell that's irritated. It's going to go cell to cell. You're going to have a wide and bizarre QRS. This is a terrible looking strip. I am really concerned for this patient, okay? There's so much going on with this strip. But again, where do we start? Try and find the most normal looking beat you can find, okay? I'm just gonna start here because I see a P wave, okay? So the SA node is firing. We've got a nice normal QRS here. We've got an inverted T wave. That's not good. This patient needs to be in the cath lab. Moving on, we have the same beat. Moving on, we have the same beat. And then we have the T wave. And then we have this wide, bizarre, early beat right here. That is your PVC. Okay, moving on, we've got a sinus beat, but it has that inverted T wave, sinus beat, and then look, we've got another wide, bizarre, early beat. Okay, we're going to kind of explain those in a second. This is coming from two different cells that are irritated. There's one cell, and that's the pathway it creates, cell to cell through the ventricles. This one looks different. It's coming from a different cell and it's following a different pathway. So it looks different focus. So let's go ahead and clarify that. When we look at our strip, this is a 6-second strip. I see some weird stuff on here. Let's find our most normal beats and find our underlying rhythm first. I see a P, QRS, T, P, QRS, T. Same thing right here, same thing right here. And then we've got something early, wide, and bizarre. That is a PVC. Okay, and then I see we have another PVC over here and it looks exactly the same. This is coming from the exact same cell. One cell that's irritated. So how would we label this strip? What's our underlying rhythm?
Sinus rhythm with
Sinus.
PVCs.
Yes, sinus rhythm with unifocal PVCs. Nice. It is not a normal sinus rhythm. You were right. It's coming from one focus. Multifocal PVCs, again, I see some weird stuff, but let's find what's normal first, because we've got an underlying rhythm here. I see a P wave and a nice QRS and a T. I'm happy. Ooh, this looks good. And then look at this. It's early, wide, bizarre. Okay, that's a PVC. And then we've got some other beats here. So I'm seeing we have some sinus. And then I see a different PVC here. So this is coming from two different cells, two different ectopic foci. So what would this one be labeled?
Would it be sinus rhythm with the multifocal PVCs?
You got it. That's it. You guys are awesome. Don't forget, PACs, PJCs, PVCs are features. They are not their own rhythms. So find what's normal, find the underlying rhythm. All right, so we know that this is unifocal. All those PVCs look the same. So how would we label this strip?
Sinus rhythm with unifocal PVC.
You got it. And then this would be a sinus rhythm with multifocal PVCs. All right, bigeminy PVCs. This is when there is a PVC every other beat, okay? But we do have some normalcy-ish somewhere here. I see like a little P wave here. I see a QRS. I see a T. And then, yes, there's a PVC here. And then it's hard to tell what this is, if this is even a P wave, QRS, T somewhere, another PVC wide bizarre, and then I've got a PVC. So let's count 1, 2, 3, 4, 5, 6. I would call this a sinus rhythm with bigeminy PVCs. Bigeminy PVCs are every other beat. There it is again.
I'm sorry.
Yes.
So, going back to the other slides, in order for it to be a PVC, the QRS had to be wide and bizarre looking.
Yes. So remember when we have our 5 steps of EKGs, the QRS needs to be present and less than 0.12 seconds. Okay, so when we look at this one, this is definitely very narrow. And then this one is going to be right at or a little bit above 0.12. It's wide and bizarre. You can already see it's wide and bizarre. Okay, it's not going to look like your normal narrow QRSs. Another example here, P, QRS, T, I think, and then a wide bizarre. And it's every other beat. Okay, so we've got sinus, PVC, sinus, PVC, sinus, PVC. Okay, so sinus with bigeminy PVCs.
Can bigeminy be multifocal as well, as long as it's still every other beat?
Yes, who was that?
Alexis.
Alexis, yes ma'am, it sure can, absolutely. That wouldn't be very pretty, would it? Trigeminy, every third. Quadrigeminy, every fourth. I'm kind of scooting through these because I'm looking at the time as well. Couplet, oh, look how cute, it's a couple. 2 of them right next to each other. That's not a good thing, okay? So when we talk about critical thinking and looking at your patient, if you're seeing a PVC, you should be thinking, oh, how are their electrolytes? How is their oxygen? What's going on there? And then if you start seeing multifocal PVCs, that's worse. Okay, that means you have more than one cell that's getting irritated. If you see them, moving from every fourth to every third, it's getting worse. Once you start seeing a couplet together, 2 in a row, that should be a warning sign. I'm heading toward VTAC here. Actually, your patient's heading toward VTAC here. This is a warning sign. Don't let this go unnoticed. This is a PVC couplet. What's the underlying rhythm? We've got a P wave, QRS, T.
Sinus rhythm.
You got it. Sinus rhythm with a PVC couplet. Run of VTAC. VTAC is 3 or more PVCs in a row. Okay, so if your patient had this and you needed to call the provider and give that S-bar, how would you describe this rhythm?
The patient has a sinus rhythm with a run of VTAC.
Very close. We're getting there. So what kind of a sinus rhythm? Sinus.
Tachycardia.
Tachycardia. Good. With a 1, 2, 3, 4 beat run of VTAC and additional PVC right here. This is the important part, honestly. Okay, nice job, guys. Whenever you see VTAC, you want to count those beats. And if you see this, guess what? And it goes back to a sinus rhythm, don't celebrate, coming back. All right, these don't just go away on their own. You have to treat the underlying cause. Something's going on here. VTAC again. And so these are wide ventricular impulses. These are rapid electrical discharges from the ventricles from one irritable electrical focus. So you see they all look exactly the same. This is one cell that keeps firing, one irritable cell. It doesn't have oxygen, or maybe the electrolytes are off. If you see VTAC on your patient, what do you need to do first?
Count the rhythm.
Pulse or no pulse?
Pulse.
Oh.
Check for a pulse. Yes. And if they have a pulse, they're probably going to lose it if they sustain this. Okay. They have terrible cardiac output at this point. So with a pulse, we can give them meds and oxygen. So we can give them an antiarrhythmic like amiodarone or lidocaine. If they do not have a pulse, we need to do what?
Shock them.
Shock, shock, shock. Yeah, absolutely. Shock, CPR. And we need to treat the underlying cause because, again, if we shock them and they go back into a sustainable rhythm, we're not celebrating. They're going to go right back into this. Okay, we got to treat the underlying cause. I wouldn't worry about this one too much, guys. It's called torsades de points. It is a VTAC. It's a polymorphic VTAC, and it looks like twisting of the points. So it looks like some of these are going downward and then some of these are going upward. It's treated a little bit differently than straight VTAC. We give these patients magnesium and unsynchronized cardioversion. I wouldn't worry about this strip too much, but I do want you guys to kind of be aware that torsades is a thing. It literally means twisting of the points. So you can see some down, some up, some down, some up. Things that can cause torsades. Also, we talk about like all of our drugs so much in sim and in clinical and some of these drugs that can cause long QT syndrome. Does that ring a bell for anybody? This is what it can lead to. The long QT syndrome can lead to torsades de points. VFib, defib, right? This is a chaotic rhythm, discharge of ventricles from multiple irritable electrical foci in the ventricles. Okay, so remember with VTAC, it was one cell that was irritated that kept firing. VFib is multiple cells. They're all firing. It's chaotic. Okay, the treatment is defib, rapid defib. Okay, I don't even think I need to go through this one. Asystole, first thing we need to do is verify in 2 leads. Okay, Let's talk about blocks. Who needs a little help with blocks? Okay, I see one hand. I can only see like 3 of you at a time. So I'm assuming there's hands because I needed help with this one too. Blocks. Did you hear that cheesy story? Did Dr. Haylett tell you the cheesy story about the AV block family? It's on the recording too, and I still think of that story. So if you need some help with blocks, listen to the recording. It'll help you with that. Blocks. There's first degree, there's second degree type 1 and 2, and then third degree. They get worse as they progress. So first degree AV block, that's actually the most benign. And then if they get into second degree type 1, that's worse. Second degree type 2, that's worse. Third degree complete heart block, that's the worst. The only thing with first degree AV block, because it's the least bad of them all, it's not its own rhythm. This one, just this one, is a feature, okay? So remember that. Let's decode this. And so we've got a P wave, and then we've got a QRS and a T. P wave, QRS, and a T. So we do have an underlying sinus rhythm through all of these beats. But with a first degree AV block, the PR interval is greater than 0.2 seconds. So you look, let's find one of those P waves that starts right on a big box. And you can see the beginning of the P to the beginning of the QRS is long. It's longer than one big box, longer than 0.2 seconds. So the impulse is originating in the SA node. Look, we've got a nice P wave here, but it's delayed or blocked in the AV node. Remember, the AV node usually hangs on to it for just ever so slightly and then releases it to the bundle of His. It's just hanging on to it just a little bit longer. There's a little bit of a block there. So again, this doesn't even require treatment. We're going to monitor this patient. We want to make sure that they don't progress into other AV blocks. Does anyone need an explanation on this further? One more thing is the PR interval is the same on every single one of these beats. Okay, so once you measure one, they're exactly the same, greater than 0.20. Gotten worse. Second degree AV block type 1. We are our own rhythm here. This is not a feature. This is its own rhythm. Okay, I'll explain why. So it looks like, where do we start, right? We'll start here. I see a P wave. So we've got, there we go, nice P wave, nice QRS. I'm so happy. It's looking like a sinus rhythm right there, right? And then we've got a P wave. Oh, great. SA is still working, but now look, it's longer. So we know, oh, something's going on here. And then we've got a P wave longer, and then we've got a P wave with no QRS. Okay, because we don't have a QRS, it's no longer a sinus rhythm because it's not following through from the SA to the AV to the rest of the heart. Okay, we have a dropped beat here. It's no longer a sinus rhythm. Second degree AV block type 1, it's also called Wenckebach. It's a little more fun to say. He was a Dutch anatomist. So anyways, it's long, longer, drop. Now you have a Wenckebach. It's when the PR intervals become longer until a QRS drops off. Long, longer drop. Now you have a Wenckebach. Spelling does not count on this test. So if all you can think of on a test is Wenckebach, then you just spell it the best that you can. Okay, you can either call it a second degree AV block type 1, or you can call it Wenckebach, either or. Okay, we've gotten worse here. Second degree AV block type 2. Okay, and I always do this. I see my fingers just like this, 2, because the PR intervals, when they're there, they're always the same and they match up. So I think of my fingers as calipers, and they're always, those PR intervals, when they're always the same. Okay, so we see the strip. It doesn't look great. Where do we start? I see a P wave before a QRS. That's the most normal thing I can find. So I see a P, I see a not so normal QRS here, okay? And then a T, and then a P, a kind of wide QRS, and then a T. So we're seeing this, but it's still looking okay. But then we have a P wave with no QRS, okay? So we know that we have a block. There's a P wave, there's no QRS, there is a block here. How do we know what type of block it is? When we do have P waves, the PR intervals are always the same. So some sinus impulses are not conducted through the AV node. The PR interval is the same and normal when present. And we're probably going to need some treatment here. This patient is only having 1, 2, 3, 4, 5, 6 kind of ineffective heartbeats here. So they have probably pretty poor cardiac output. 60 beats a minute, not following a great pathway here. We might need pacing here. Is everyone good so far? Okay. 3rd degree AV block, the worst. Okay, your patient is probably not doing very well at this point. It's the most clinically significant. The impulse from the SA node is not conducted to the ventricles. And every sinus impulse is blocked by the AV node. So in 3rd degree AV block or complete heart block, the SA node is doing its thing. And the AV node is doing its thing quite slowly, but there's no correlation in between, okay? Let's try and look at this strip. It's looking bad. Where do we start? I see a P and then I see a QRS here, okay? But it's wide. I can already tell we're gonna not have a great rhythm here. And then we've got a P wave with no QRS. So there's a block here. We know it's a block. And we've got a P wave and a QRS. And then a P wave with no QRS. We know we have a block, but which block is it? We have to look at the PR intervals, okay? So I see one here, it's greater than 0.20. I see one here, it's dropped. I see one here, it's really long. I see one here, it's short. There is no correlation between my SA and my AV node. This is a 3rd degree AV block. Does anyone else need anything repeated for AV blocks? They seem to be tricky for most of us.
So to talk about the PR, 1st degree is just long. 2nd degree type 1 gets longer drop. 2nd degree type 2, it stays about the same. But with this one, the PR is kind of inconsistent. It's kind of big, little, big.
It's absolutely inconsistent because the SA node and the AV, they're not connected. They're doing their own thing.
Yeah, they're divorced. They're crazy.
They're divorced. Yes, absolutely. Okay. Great sum up. This is a great video. I love how this guy goes over this video, but he shows where the blocks are if you want a little more detail. That's the sad story of the AV block family. I'll just tell you really quick. This is a SA node is the wife, the AV node is the husband, and every night the husband comes home, but he's late. But that's okay. Their marriage is still okay. But every night, there's the wife, the SA node. She's waiting, and he comes home late. Whoops. And then 2nd degree AV block type 1 is he comes home on time, and then the next night he comes home later, and then one night he doesn't come home at all. The drama. Type 2, some nights he comes home, and when he does, he's always on time. But then some nights he just doesn't come at all. And then this is, like Grace, you said, a divorce. She's doing her thing, he's doing his thing. There's no relationship in this PR interval at all. Idioventricular, this is the pre-death rate right here. If you see this, your patient is passing, okay? Idioventricular rate, it's when the SA node fails to fire. The AV node fails to fire. And the Purkinje fibers deep in the ventricles are firing at 20 to 40 beats per minute. It's like in our first slide when we were talking about the 3 areas that can fire. The Purkinje fibers fire between 20 and 40 beats per minute. And remember, it's not coming from the AV node, so you're not going to have a nice narrow QRS. You're going to have a wide, bizarre, really strange cell-to-cell pathway that's taking forever in the ventricles. Pacing, you guys can kind of go through these, but there's atrial pacing, there's ventricular pacing, and then there's both atrioventricular pacing. Okay, so for instance here, this is ventricular pacing. This is the pacer spike, and it's going to signal whatever to fire. Okay, so if it's before a P wave, then it's going to be atrial. If it's before a QRS, it's going to be ventricular. It can be both, just like this one. So this is a atrial right there, and then this is the spike for the ventricular. This is AV pacing. Defib, you guys know that and have this slide, everything's here. Pad placement, you have all of those, cardioversion. So everything you have is here, okay? We are exactly at 10 o'clock. I can't believe we got through all of that. You guys are good. What questions do you guys have?
For those, someone else is going to come in at, I think, is it 11?
Yes.
Now, I know you're recording this. Is that one going to be recorded too? Because I'm not going to be able to make that one.
I think we can request that. There's no reason it shouldn't be recorded. So absolutely. Is there anything that you would like for him to focus on? Because we've been in contact as well.
I guess maybe, or I mean, just examples, just examples. I think it's just more about practicing seeing it than just, because
Okay.
I think we have a good idea. I think I have an okay idea, but as you see it and see it and see it, it's just, practice.
Absolutely. Would you like me to stay on for 15 more minutes and go through some strips?
Yes, please.
Yes, please.
Do it, and then if you guys want to stay on, you can stay on. But we do have a resource in Canvas for you. The practice strips, has anyone done those yet?
I've printed them.
Yay, let's go through them, okay? Let's go through them. I'm gonna move this, I'm gonna X out of here.
All right, so quickly while you're doing that, I just want to say thank you so much, but I do have to leave. I have a meeting at 10, but thank you so much. You're amazing.
You are so very welcome. This is recorded, so hop back on if you want to.
Yes.
And we'll see you later. Good luck on this
All
test.
right, have a great day.
You too. If anyone else needs to hop off, I totally get it. It's fine. You're not going to hurt my feelings at all. Okay, so let's look at this first strip. And I need you guys to kind of help me out with this. Okay. So tell me anything that you see that you want to talk about. Where do we start?
I guess to find the underlying rhythm.
Yeah, do we see anything normal on here? It looks pretty bizarre to me, but
Yeah.
I see a P wave before a QRS right here. So I see a P and then I see a QRS. So I guess we could start there. There's nothing really great looking about this rhythm. So we've got a P, we've got a QRS, we've got a T, we've got a P, and it looks like, wow, this is either a really long PR interval or a drop. QRS, T, P, completely different PR interval, QRS, T, really close P. Okay, so we know that we have a block here, right? Because we've got a dropped QRS. And then are the PR intervals, what do they look like? Let's look at this one. Let's look at this one. This one doesn't even have a QRS. Are the P's and the QRSs even correlated? Any guesses?
Would it be a third degree?
Stacy, you got it. This is a third degree heart block. Rock on. Okay, so this is a terrible rhythm, and I feel like as they get worse, they get a little harder to read because there's nothing normal. But then also they get a little easier to read because they're very characteristic of a third degree heart block. So that is awesome. Okay, so what we have here is our PR intervals are not correlating at all. Sometimes they're short, sometimes they're long, sometimes they block. Like it's just a third degree heart block. This is a little bit of an easier strip, I think. Okay, so where do we start here? This is a 6-second strip. It looks prettier, I can say that already. We can start with our 5 steps on this one because we have some better features here or better characteristics here. So number 1, rhythm. Is it regular or irregular?
Regular.
It's regular. Awesome. And then what's the rate?
80.
Yep, 80. Okay, I'm liking it so far. Is there a P wave before every QRS?
No.
Ooh, okay, so we've got a problem there. And then is the QRS present and narrow?
Yes.
Okay, and then we can't calculate a PR interval here. So this looks like a great strip, except the only thing is there's no P wave. I'm not seeing it. It's absent. So what do we have? It's absent on every single one. What is this? It's the rhythm where the P wave is absent.
Functional one. The
Junctional rhythm. It's either P wave is either absent or it's inverted in lead 2. This is a junctional rhythm. It happens on every beat, so it's its own rhythm. Number 3. Okay, I can already tell what this one is. I wonder if you can too. We can start with our 5 steps. So is it regular? Nope. Irregular. Okay, and then what's the rate?
$90.
90. Okay, I'm cool with that. Is there a P wave before every QRS?
Yes.
Hard to tell. I can't tell if this is a P wave. Maybe if it is, it'll look the same on the next one. Ooh, that almost looks like it's inverted. I can't tell if that's a P wave. If that is a P wave, it looks different than that one. This is actually chaotic down here. I can't tell what's a P wave. So it's irregular and we cannot differentiate the P waves. The QRS is present and it's narrow. What do you guys think this one is?
AFib.
AFib. Good. Awesome. I want to stay on here for just a minute. And AFib, remember, the problem is in the atria. It's in the P waves. VFib, the problem is in the ventricles. It's going to be in the QRSs. QRSs will be wide and bizarre. Okay? So I notice a lot of folks will say AFib when it's VFib and vice versa. Okay? AFib, the problems with the P waves, the atria. Nice job. Okay. Here we go.
Asystole.
Thank you. And what do we do for this patient first thing? I think someone said, oh, go ahead.
Check the leads.
Yes, please. Absolutely. Oh, let me go back to this one. I don't know why. Okay. Even with asystole, you see it's not like straight like a board. It can be a little wavy. That's okay. All right. What do we have here? Where do we start? Step 1, is it regular or irregular?
It looks regular, but it looks like that sawtooth.
It does, for sure. Okay. And then our rate is 1, 2, 3, 4, 5, 6, 70. And then the P wave before every QRS. Yeah, we do have that, but you're right, Stacy. I'm seeing that sawtooth. right? So what do you think this is?
The atrial flutter.
Atrial flutter, sawtooth, absolutely. So we've got a P wave. There's another P wave right in here. P, 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 P. So it just keeps going. Atrial flutter. All right, what do we have here?
VFib.
VFib. Why is this VFib, guys?
There's no QRS complexes.
Exactly. And it's just chaotic and really bizarre. You can't differentiate anything here. Very nice job. What do we do for VFib? It rhymes. DFib. Okay, good. And then, ooh, 7. Gosh, where do we start here? This doesn't look normal to me. I'm going to start where I see a P wave and then a QRS and a T. Okay, so I see a sinus beat in here. And then P, QRS. Not really seeing a T, but I'm seeing a very early wide bizarre and early wide bizarre. P wave, QRS, T. So our underlying rhythm is what? What are these beats?
Sinus.
With
The couplet PVCs.
absolutely good. So let's go ahead and finish that. So it's going to be sinus what with PVC couplets?
Tachycardia.
Sinus tachycardia. If we count these QRS complexes, we get over 100. Sinus tachycardia with PVC couplets. You guys are doing so great. Okay, I see a wide QRS here, but let's start somewhere. They all look the same. And so it looks like they're regular and the rate is 60, right? And then we're going to start looking for a P wave. Is anyone seeing a P wave? Okay, so there's no P waves. And then the QRS is present, but it's really wide. And there's no PR interval. What do you think this could be?
Is it the junctional rhythm again?
It could be, but typically junctional rhythm has no P wave or an inverted P wave right here, but the QRS usually looks really good. It's nice and narrow because once it gets to the AV node, it's okay. Where do you think might be making this impulse? It's not the junction.
Is it the idioventricular rhythm?
It is. Okay, this is a tricky one. Who said that one?
Logan.
Logan, awesome. It actually is. It's an accelerated idioventricular rhythm. So this is just originating in the Purkinje fibers, but it's still a little bit accelerated. We know it's not sinus or it's not a junctional rhythm because you're right, it has the junctional no P wave, but the QRS, there's something wrong with the ventricles. This is wide. So that is IVR. Let's look at this one. You guys will get this one. I'm not even going to say anything on this one.
The sinus bradycardia.
Good thought. Not exactly. Keep looking.
Is it the junctional escape rhythm because the P wave's inverted?
Yes, absolutely. Okay, so good thought on the bradycardia. You're right, it's slow. Okay, but we've got to look at those P waves and they're inverted. Okay, so inverted on every one. So we've got a junctional rhythm or a junctional escape rhythm. Either is fine to say. Does everyone understand that one? Okay. Okay, so there's a couple things that I like on here. I see narrow QRSs, but I'm already seeing that some QRSs are being dropped. So where do we start with this one? We already know if a QRS is being dropped, what do we have?
A block.
We have a block. Absolutely. We have a block, but we now have to figure out which one is it. Okay. So I'm going to start with my most normal beat, which happens to be this one. I see a P wave and a QRS. I'm so happy. And then I'm seeing a P wave, and then there's a longer here, QRS, and then a T, and then a P wave, and then even longer, QRS, T, and then drop. So I have a, looks pretty decent, but then a longer drop. Now we have a
Wanky Bach.
Wanky Bach, second degree type 1. You got it. Does everyone see that? Do you need me to go over that one again? Okay. All right. Sometimes it is what it is. Number 11, what do we have here? Let's go through our steps. It's looking like a pretty nice, decent rhythm. So we have some things to interpret. Looks regular. What's the rate?
$90.
Okay, great. And then is there a P for every QRS?
Yes.
Yes. QRS is nice and narrow on every one. Okay, so what do you think we have here?
I see a ST depression.
Ooh, nice. Very, very detailed. I do see some ST depression. Okay, so how would we label this strip?
Sinus rhythm with ST depression?
Yes, absolutely. It's not normal sinus rhythm, right? Because not normal. We have some ST depression. Really great job on catching that. So your ST depression is going to be when you're creeping up to that baseline or isoelectric line. So you see it right there. Really good job, guys. All right, what do we have here? Looks like we've got this straight line and then kind of, it's paced. What kind of pacing?
I don't know.
Yeah, you do. I promise you do.
Ventricular?
Ventricular, yeah. So we've got the spike, and then what comes next, Stacy? The QRS. You got it. Okay. Nice job. Who said ventricular?
Alexis.
Alexis, it's you again. I don't know why I can't see you guys. Maybe your cameras are off. Ventricular paced. Okay. And for even more detail, you know, there's 100% capture. So every time there's a spike here, we have a ventricular beat, okay? So this pacemaker is working very well for this patient. Sometimes you might see a spike and then there's nothing after it and there's no capture there, and they might need some adjustments to their like the voltage or amps, okay? So there needs to be adjustments sometimes with pacing. All right, another, it is what it is. This looks pretty nice. I think we can interpret that. What are you guys seeing?
Sinus bradycardia.
Okay, why do you think it's sinus bradycardia? Because you're right.
I see a P wave before the QRS.
Yes, good. So it meets that criteria. Why else is this sinus bradycardia?
The rate is 50.
Okay, good. Very good. 1, 2, 3, 4, 5. The rate is 50. And is it regular? And the QRSs are nice and narrow, less than 0.12. And the PR intervals are less than 0.20. Really nice job. All right, let's look here. I see a couple little wacky things on here, but underlying rhythm looks pretty good. You guys go ahead and do this one.
It's a multifocal PVC?
Yes, that's the feature that's on there. Nice job. What's the underlying rhythm?
Should be sinus, right?
Sinus rhythm with multifocal PVCs. Really great job. Okay, so you're going to find the most normal looking thing, and we'll start right here. P, Q, R, S, T. That looks like a beautiful sinus beat. It's just absolutely love it. Same thing here, and then we've got an early wide bizarre PVC, and then sinus, 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 and a different PVC here. So it's coming from a different irritable ectopic focus. Really great job. If you were to answer multifocal PVCs, that wouldn't be the answer to this. So make sure that you've got the feature and the underlying rhythm. Do you guys remember which features there are? What things are features?
The PJC, PVC, first degree, and PAC?
You got it. Absolutely. Okay, so remember that. Very nice job. Okay, let's look at 15. At first glance, it looks really pretty decent to me. Okay, so let's start interpreting. I'm looking at the tops of the QRSs. It looks regular, except for that one. Looks like we've got something premature here. And then it looks like we've got something premature here as well. Again, what works really nice is if you've got a paper and you line it up to your first few QRSs and make a little line on your page and then kind of just march them over, okay, to see if they line up. All right, and then it looks like we have a PQRST. I'm happy. PQRST. Ooh, we're looking good. PQRST, still good. And then something's going on here. We've got an early beat, and I'm not seeing a P wave. And then moving on, I see a sinus beat here, PQRST. Oh, I see an early, no P wave. T, PQRST. What do you think we have here? Underlying rhythm?
Sinus.
Sinus rhythm with?
Is it PACs?
Okay, so I'm not close. I'm not seeing a P wave here. You would see a P wave with a PAC. It would just look different than these P waves. So if the P wave is absent or inverted, what is it?
Is it a PJC?
A PJC, absolutely. So this would be sinus rhythm with PJCs. Your PJC is right here and right here. Okay. Good job. All right. Wide, bizarre, and it looks exactly the same in rapid. What do we have?
VTAC.
VTAC. What do we need to do for someone with VTAC? First thing. Yes, I saw someone mouth it, but what?
Check for pulse.
You got it. Absolutely. Okay, VTAC. All right, and remember, if they have a pulse, we need to provide oxygen, and we'll need to get some antiarrhythmics as well. If they do not have a pulse, defib. Number 17. Sometimes it is what it is. Don't make it harder than it is. What do we have here?
Should be sinus tach, right?
It is sinus tachycardia. So we have a regular rhythm. These are equally spaced. We've got a P before every QRS all the way down. And our rate is, was it 120? 6, 7, 8, 9, 10, 11, yeah, 120-ish, okay? Sinus tachycardia. All right, this one looks a little weird. I like the narrow QRS, so our ventricles are working pretty well, but what's going on here?
Is it a sinus rhythm with first degree block?
Yes, Maggie, Awesome. That's exactly what it is. Okay, so we've got a regular rhythm here. We've got a P before every QRS. The QRSs are nice and narrow. We don't have any ventricular issues, but that PR interval is long. It's longer than 0.20. So remember to use that trick and find one of those P waves that starts on a line. So this one starts right here on this big box, and you can see the PR interval is longer than one big box. So this is a sinus rhythm with a first degree AV block. Nice job. What do you guys see?
Would you call that the torsades one or no?
No, it looks like all of these are going downward, wide, bizarre, from the same ectopic focus really fast. We already had one of these, but it looked a little different. So if we're looking at this and we see that this is the QRS and it's wide and bizarre, we know we have a ventricular issue. And it's fast, so we know it's tachycardic. So this is another VTach. Okay, I'm going to scroll back and we're going to find the other VTach just so you can see they're a little different looking, but they're still VTach. Okay, we're looking at that wide, bizarre, exactly the same, and rapid. That's VTach. This is as well. So I just want to remind you that they can be the same rhythm, but still look a little different, but they still have the characteristics, the same characteristics. Okay. All right, let's do a couple more. I don't like this rhythm at all. I'm worried about my patient. What do you guys see?
There's no QRS complexes on two of them, so it's a
Yeah.
drop.
So we know we have a block.
Block.
We just have to figure out which one. Okay, so now we can go to the P waves if we have any. And I see a P wave here and one here as well. And the PR intervals are exactly the same. They march out. Same over here. So which block is this one?
Second degree type 2?
Second degree type 2. So if I'm looking at this on my screen and I'm trying to measure my PR interval, I'm actually doing this with my fingers. I'm actually measuring them. Like this is calipers and they are exactly the same. And look, I've got 2. Second degree type 2. That's how I remember this one. Okay. All right, what do we have here?
Is it sinus tach?
This is a sinus rhythm for sure. I'm just counting right now. I see a beat right here, but 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. It's around 100. So this would actually be a normal sinus rhythm. All right, moving right along. All right, let's use our steps. Do we have a regular rhythm? Do these mark out?
So 21 was just a sinus rhythm?
Yeah.
Okay. It looked like it was kind of jagged in the first half and then it kind of smooths out, so I didn't know if that meant anything.
I'm glad you said that. And that can just be from movement of your
Okay.
patient. So a little bit of artifact, but you can still see the P wave. You can still see the components and they all look the same. Great question. All right, number 22, this is irregular. What's the rate?
$80.
That's what I got too. And then is there a P for every QRS?
No.
New.
I can't tell what that squibble squabble is. So this is, okay, we can't define that. And the QRS is present and narrow. So do we have an issue with the ventricles? QRS looks good. The problem's going to be with the atria. So what do we have here? I cannot discern these P waves.
Is that the PACs?
So a PAC is going to be a feature. You're going to have a normal underlying rhythm, and then you're going to have PACs as features. It looks like with every beat, I can't tell. Is that a P? I don't know. I can't tell. That kind of looks like a P, but I can't tell. Maybe bumpity bump, bumpity 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 bump, and it's irregular. This is actually atrial fibrillation. Key points, we know it's an atrial issue, it's irregular, and we cannot discern our P waves. Okay. Usually atrial fibrillation kind of creeps up and gets a little faster because the heart gets really excited with all these impulses. So just to let you know, sometimes it's with a controlled ventricular response, but if it's over 100, it's a rapid ventricular response. 23. Looks really chaotic. Go ahead.
VFib again?
VFib, good. Well, you see VFib, what do we need to do?
Defibrillate?
Defib, you got it. Okay, super. Moving on to 24. I see, oh boy, this looks like a regular rhythm. So they're equally distant. And what is the rate on this?
180?
Woo, boy, that's really up there. Okay, so a narrow QRS complex, really rapid, greater than 150, regular rhythm. Any guesses on this one?
SVT.
SVT, supraventricular tachycardia. Good, very good. I said I was going to stay on for 15 minutes and I see it's 34 after. I'm happy to stay, but if you need to go, I understand. Okay. Sinus rhythm with ST elevation is what's going on here. I'm going to go ahead and kind of wrap up. So we've got a P wave, QRST, P wave, QRST, P wave, QRST. So we have a sinus rhythm here, but with every beat, you've got ST elevation. That ST segment is way above the baseline, the isoelectric line, okay? When you have ST segment elevation or depression, you're gonna see it on every single beat. It's not just gonna be one, okay? 26. All right, we see this rate is 30. These are very wide and bizarre. Where do you think this impulse is coming from?
The ventricles?
Mm-hmm. Deep, deep in the ventricles. It's those Purkinje fibers. So what rhythm is this?
Is it the idioventricular?
You got it. Idioventricular rate between 20 and 40 typically. Wide, complex, absolutely. 27. Okay, it looks like we have a PQRST, PQRST. They all look the same. They're equidistant, but what's the rate? Ooh, it's hard to count.
Would you count that last one?
Yeah, I would.
Okay. So it's tacky, definitely.
Oh boy, it's like beyond. Yeah, what is the rate? 100 and
I think it's 180, but my math
so
might be
too.
off.
I think it's about 180 as well. So it's a narrow QRS complex, regular rate that's greater than 150. You got it. I saw you say it. Mouth it, Stacy. SVT. Okay. Supraventricular, above the ventricles. There's no ventricular issue here. Okay. Ventricles are just kind of following, what the atria are telling them. SVT. 28. This does not look very pretty. So I can't really tell if there's a P wave here. I can see that it's regular, but I do see a little P wave here and a little P wave here. So we can go ahead and say this is a sinus. The QRS is not looking very good, but we do have a sinus rhythm here at 30. So what is this?
Would it just be sinus bradycardia?
It would. This patient needs some severe help right now.
Would those
so.
classify as tall tinted T waves?
They, we would look at their electrolytes just because they have, this is not a normal looking strip, but tall tinted T waves would probably be a little bit higher than that and more marked, but good notice. 29. We're almost at the end.
Is this the PJC since it's inverted, the P wave?
I see an inverted P wave here, 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 here on every single one. So this is a junctional rhythm. Yeah, so whoever said PJCs, you're on the right track, but a PJC is, remember, it's a feature and it won't happen on everyone. When it happens on everyone, you have its own rhythm. This is a junctional rhythm or a junctional escape rhythm. Last one. All right. This is an interesting looking one. We'll start with our steps. Is it regular? No.
No.
Good. And then the rate?
100.
90, 100. Okay. And then is there a P wave before every QRS? It's not discernible. Looks a little wavy in between there. The QRS is present and it's narrow. We can't determine a PR interval. So what is this one? We cannot discern those P waves. It's irregular. Atrial fibrillation. Okay. And that is the end. You guys did a lot better than you think you did. It takes a lot of practice, and I appreciate you guys sticking in there with me. Any questions that I can answer before we head out today?
Well, thank you so much.
Welcome.
Yes, thank you so much.
Thank
That was really
you.
helpful.
Thank you.
You are so welcome. Good luck on your test. Keep practicing. There were a couple resources on your PowerPoint that Dr. Hallett gave you. I think SkillStat was one of them. And as you go through resources, just remember, if you see something, a new rhythm that we didn't talk about, that's not game for your test. Okay, so what's on the PowerPoint, what we've gone over, that's what you need to focus on for your test. Okay, so like you'll see bundle branch blocks and all kinds of other things. Don't worry about that. It's just what we taught you. Okay? All right, take care. Reach out to me if you have any questions.
Yes, thank you.
Thank you.
You're welcome. Bye-bye.